Welcome to this presentation on how does documentation play a role. In the world of real estate, there are three key words: location, location, location. In the world of clinical revenue cycle, there are three key words also. They are documentation, documentation, documentation. There are a number of requirements for high quality documentation, but the four key ones are legibility, which really is no longer an issue. Number two, precision and consistency. Need to tell the story and need to tell it accurately. The third one is timeliness and clarity. Documentation needs to be present in a timely manner, and it needs to be clear. It needs to be totally understood as to how the patient's story is being told. And number four, reduce copy and paste. And if copy and paste is being used, it should be copy and paste and edit. That is the key factor that is consistently missing with the use of this technique, or possibly with the abuse of this technique. It's important to understand, what do we need to document? Well, the first thing is the primary diagnosis. And then add to that all diagnoses that impact the patient's care, evaluation, and treatment. After that comes coexisting acute conditions. One thing to keep in mind is do not use history of, because if it is actively being treated, then it is not history of. For example, commonly seen is in the coexisting acute conditions, history of breast cancer on tamoxifen. Well, the patient is being treated with tamoxifen, so it is not history of. It is actually a condition that needs to be addressed. After that come chronic conditions. And keep in mind that the treatment must be monitored, evaluated, or treated in order to be integral to the documentation. Lastly, conclusions and diagnosis. We'll go through this in a little bit in the assessment and plan and get some pointers on how best to provide the assessment and plan. You have to remember that in the discharge summary, probable, possible, suspected, and likely can be used. And also, the discharge summary is the rescue document and can be updated. Don't wait until the last day, though, to do your discharge summary. And finally, the rule of three. Document it 3 times: the history and physical, in the progress notes, and in the discharge summary. Keep in mind that although this presentation is considering what's in the federal regulations, documentation should be payer blind. In other words, I like to use the fee-for-service Medicare regulations as the mantra, as the direction for best documentation, and it can also be utilized in different ways for the other payers, period. In the Medicare Benefit Policy Manual, Chapter 1, Section 10, some general documentation takeaways are given, and that is the 5 key pieces of documentation for Medicare cases and determining medical necessity of inpatient care. Those 5 key pieces are the medical history, the current medical needs, severity of signs and symptoms, the facilities available for adequate care, and the medical predictability of an adverse outcome. We'll get into that in a better definition as we proceed in this presentation. There are several areas for high-quality clinical documentation. Some of them apply to Medicare fee-for-service, and some of them apply across all payers. The first one is the earlier than expected discharge. It is not sufficient to say that the patient wanted to go home or there's no ride for the patient tomorrow. There should be a medical reason for an earlier than expected discharge, and that should be well documented. We all know that one-day stays are a significant area for auditing, especially in the Medicare world. Status order changes frequently do not have documentation to support why the status was changed from observation to inpatient. Auditors tend to look to see what was going on at the time that order was changed. Patient acuity is always important, and there must be sufficient documentation to support the medical necessity of an inpatient level of care. Condition Code 44 bullet point number 4 has to do with the statement that there needs to be documentation of the process and what was going on. And lastly, one that I sometimes recommend but must be used cautiously is a statement in the assessment and plan to say that, and these services could not have been performed in a lesser level of care. When doing physician education for documentation improvement, I used to hear many times that I don't know how to take what I know clinically as far as patient care is concerned and transition it into a level of care, that being inpatient or observation. So I like to make it simple with 4 guidelines: suspects, concerns, predictable risk, and intent for treatment. They're very easy to remember, and add to that, why does or doesn't this patient need an inpatient level of care? And what's the plan? What's the plan of treatment? We should try to document this initially and every time there is a status order change. Keep in mind that the discharge summary is many times considered the rescue document. It is especially helpful with CDI, clinical documentation improvement, or clinical documentation integrity. But the discharge summary should include a brief summary of the history and physical, the hospital course, final diagnosis or diagnoses, discharge meds and plan, and lastly a statement that says stable for discharge. This is very important when it comes to readmissions or potentially for medical legal interactions. I mentioned before 4 key simple bullet points, and these should be used for the assessment and plan. And they are again suspects, concerns, predictable risk, and intent for treatment. There is a half a guideline that I use or teach, and that is the word because. Suspects. What does the physician suspect is going on? What is the differential diagnosis? And even with the listing of the differential diagnosis and possibly even the problem list, it should be realistic. There should be something going on in order to include that diagnosis in what you suspect is going on or the differential diagnosis. The next one is concerns. Do you have high or low levels of concern for predictable events? We always think as physicians, what could possibly go wrong with my patient? Do we have high or low levels of concern for those risks? Next is predictable risk. How predictable are those risks that we're concerned about? Now, as a rule of thumb, I suggest that physicians think this way, considering the challenges that they have in determining a level of care. If you have high levels of concern for highly predictable risks, those patients tend, keyword tend, to be inpatient. If you have low levels of concern for low predictable risks, then they tend to be observation. And also if you're putting a patient in the hospital for a workup, they also tend to be observation. Lastly, you do need an intent for treatment. What is your treatment going to be? And in the Medicare world, the Medicare fee-for-service world, an intention for a 2-midnight stay. The word because becomes a nice transition word. I'm admitting this patient as an inpatient because, I'm ordering this test because, etc. These 4.5 guidelines do not obviate the need for a problem list, but should be incorporated into the problem list. Keeping those 4.5 guidelines in mind, let's go through a couple of examples to help delineate the principles behind all of this. Here is a template that becomes very useful and gives a great example of how those 4.5 guidelines can be used. Inpatient, outpatient observation level of care is warranted for this patient because he or she presents with, and here you can list your suspicions, and I have a high or low level of concern for, and it must be a diagnosis, not just a symptom. These are your concerns, as he or she is at high or low risk for, and here's where you could list your predictable risks. Then we must include a plan of care, treatment, including the need for a 2-midnight stay in the Medicare fee-for-service world. And most commercial payers, at least at this point in time, are not utilizing the 2-midnight rule. I should say that They state that they use the 2 midnight rule, but it is not included in the contracts. Keep this in mind because I'm sure for many times you've heard a denial say, and these services could have been performed in a lesser setting. Well, the reality is that in the assessment and plan, the acuity of the patient was not presented well enough or strong enough or detailed enough to recommend an inpatient level of care. And when it came to listing the treatment, most of those treatments can be provided in a observation or outpatient level of care. So keep in mind that you must define the acuity in order to adequately determine medical necessity. Here is a real example of a assessment and plan from a patient, and obviously the PHI has been redacted. This does give a great example of how the 4.5 guidelines can be utilized. The history and physical, as stated in the chart, had a chief complaint of a fall at home with hip and rib pain. The history of the present illness stated that the patient is a 90-year-old female with a complaint of a fall at home and rib pain. According to the family, the patient fell in the bathtub and hit her left side and is unable to ambulate after the fall. She has been on oral Levaquin for a treatment of a urinary tract infection per her PCP. She gets unsteady and weak when she has a urinary tract infection, according to the family. In the emergency room, the x-rays showed left-sided rib fractures 7 through 11. No hip fracture was noted, and the patient has uncontrolled pain, so needs IV pain medication for pain control. Past medical history is significant for AFib, congestive heart failure, COPD, CVA, and hypothyroidism. At the time of the exam, the patient is resting comfortably. Now, there is a definite dichotomy in those statements. First of all, it says that she has uncontrolled pain, so she needs IV pain medication for pain control. But at the time of the exam, she's resting comfortably. The one thing that's missing there that would make this a whole lot clearer is if it said, at the time of the exam, the patient is resting comfortably after adequate analgesia. Mostly nonverbal at baseline due to dementia. Most of the information was gathered from the daughter. Would like nursing home placement. Well, the question after seeing that is this patient being admitted for nursing home placement or because of the acuity of the assessment and plan, as stated in the chart? Principal problem, multiple fractures of the ribs, left side. Active problems, COPD, dementia, hypothyroidism, etc. Plan, 90-year-old female with left-sided rib fractures, status post-fall at home, has recently been treated for a UTI, gets weak and unsteady in study with a UTI. Fall at home with left-sided rib fractures, admit for pain control, IV and oral, lidocaine patch, etc. The problem is that what's listed as the treatment can be accomplished at a lesser level of care, and the acuity is not well defined. There are a lot of things going on with this patient that would suggest the need for an inpatient level of care. So with utilization of the 4.5 guidelines, the assessment and plan was rewritten by me using the facts that exist in the chart. Assessment and plan. Inpatient is appropriate for this 90-year-old female who fell in a bathtub sustaining multiple left rib fractures 7 through 11. Risk factors include failure of outpatient management of a urinary tract infection with oral antibiotics, dementia, unsteadiness, and weakness, which typically occurs with this patient and a UTI and leads to a fall risk. And I have a high level of concern for this urinary tract infection resulting in a significant injury, as this patient is at risk for sepsis due to a UTI. Additional risk factors include elevated WBC, elevated temperature, advanced age, pulmonary complications due to lack of pain control, and COPD. Plan of care includes, and you can read the rest of that as you see it, but the reality is that the acuity needs to be well detailed and justified for an inpatient level of care before getting to the treatment plan. And lastly, not to pick on the orthopods, But the reality is this is very frequently seen, and as far as I'm concerned, one of the worst example for the justification of an inpatient level of care, where the impression states osteoarthritis of the left hip, plan left total hip replacement. Really, doctor? That is your indication for an inpatient level of care? You may say, well, that used to be on the inpatient only list, although it is not right now, but there are inpatient only procedures that are denied inpatient payments because there was no medical necessity listed in the documentation. Hopefully you found this presentation helpful to increase your documentation skills and what needs to be included in the chart. Remember those three words, those three most important words for clinical revenue cycle: documentation, documentation, documentation. Thank you.